We'll be talking about peritoneal surface malignancies and HIPEC. Uh, Thank you to Dr. Fournier for being here and to talk to the issues and questions. This is really a talk that was modified from Chris Scally's talk from last year. I thought his was really good, so I just kind of made some modifications and some updates to it. So I have to give him credit for this. Um, All right, so some objectives. We're going to go a little bit of exam review mode. There's some questions in here, so get ready for that aspect of wonderful aspect of our training. And then we're going to go over some of the treatments of peritoneal disease and appendiceal, mesothelioma, and colorectal. Do kind of a practical overview of HIPEC. Um, Hopefully, this will at least in terms of kind of the technical aspects, we're going to start making videos of the operation and kind of the setup. So those will be available as well for people coming onto the service, so you'll have a better idea of like what the setup is, how to do the Thompson retractors, and kind of the overall flow of the operation. And then some of the best evidence for the current treatment, and then also the MD Anderson experience, because I mean I think um, a lot of the second years here know that there is kind of the board answer, and then there's also kind of what we do here. So it might be a little different. So let's start with a question. So a colleague has just performed a laparoscopic appendectomy for presumed appendicitis on a 50-year-old woman. An abnormal dilated and fluid-filled appendix is found. Further laparoscopic exploration demonstrated no evidence of intra-abdominal pathology. The most appropriate next step is to await the results of the final pathologic evaluation, conclude the procedure and perform a CT, convert to an open exploratory laparotomy, perform a right hemicolectomy, or perform a right hemicolectomy and peritoneal washings. Chris, you're exempted from this. Eight? All right, so that is correct. So a dilated and fluid-filled appendix, it's a mucocele, but a mucocele, can have many causes. It doesn't have to be cancer. It can be caused by, benign causes too. So you just have to wait for the final pathology. So really, I like this diagram showing kind of the decision tree for incidental tumors of the appendix. This is again assuming that there's no evidence of metastatic disease. And really, you wait. The first step is to see the pathologic review. You'll get two branch points. Either it's going to be a neuroendocrine differentiation type of tumor, or they're going to be glands. And within the glandular tumors, you're going to have kind of the mucinous neoplasms, and then adenocarcinoma. And within adenocarcinoma, there's well and moderately or poorly differentiated. So on the neuroendocrine component, you're going to have the garden variety carcinoid tumor that we all probably had a test question on the app side at some point about. And then there's this goblet cell tumor or goblet cell carcinoid. It's been called a lot of different things kind of over time. But generally, that is not a carcinoid in any sense. It behaves more like cancer, like adenocarcinoma. And so let's start with on the right and work our way over to the left. So we're going to talk a little bit about the mucinous neoplasms. One thing to consider is that a big problem with the field has been that the terminology, really hasn't been a consensus on terminology until very recently. So this is the Peritoneal Surface Oncology Group International that really had a consensus in 2016 on like what to call things. And so I think hopefully kind of going forward, things are going to be a little more straightforward or less confusing. But if you look at some of the older literature, it's kind of hard to figure out what's what and comparing, you're not really comparing apples to apples. So in general, you have kind of, in terms of appendiceal neoplasms, you have non-invasive neoplasms and then invasive neoplasms. For the non-invasive, you have the lamins, which are the low-grade appendiceal mucinous neoplasms, the Hammonds, which are the high-grade ones, and it's kind of a new diagnostic category and it's rare. And then kind of the adenomas that we kind of know from colorectal surgery adenomas. And then on the invasive side, you have your mucinous adenocarcinomas, non-mucinous adenocarcinomas, and you have these signet ring cell carcinomas, which are bad. Signet ring cells are bad no matter where they are or where they're from. So let's start with the lamins. Lamins, like I said, mucinous neoplasms, they have low-grade cytology. You'll see the what do you call it? The catchword or the phrase is pushing invasion. So you have this expansile or diverticulum-like growth. There's loss of the lamina propria muscularis with some fibrosis, some flattening of the epithelium, and undulating growth. There's increasing incidence. In 1971, it was 0.6 per million, and now it's 2.8. Dr. Fournier and I were just talking about this before the conference, and that really has to do kind of with better diagnosis. Essentially, the pathology is better, and the terminology is better, and so there's a lot more clarity as to what exactly is what. And so a lot of these are just kind of being, there's a lot more of these being diagnosed than prior. The staging, so you have the true lamina, which is the in situ, is confined to the muscularis propria. T1 and 2 are not really applicable for the lamins, but for T3, the tumor, which could be cells or mucin extends through the muscularis propria into the subserosa or the mesoappendix. And then you have T4 tumors, which there's T4A, which really kind of is a bit of a setup for kind of overstaging when you think about, when you think about kind of mucin being spread during handling. But really, this corresponds to where the tumor penetrates the visceral peritoneum or serosa of the appendix. About 5% of patients with acellular disease localized to the right lower quadrant develop recurrence. So those patients don't generally get recurrence. But when you have cellular disease spread that's localized to the right lower quadrant, these have about a 42% chance of developing a recurrence in the future. So there's a bit of kind of dichotomy there. And then the 4B tumors are kind of directly involved with the adjacent organs. Then there's, for the M staging, there's M1A, which is acellular mucin in the peritoneum. Then B is cellular mucin, and then C is you have extraperitoneal spread. And of course, the acellular mucinous disease has a lower risk of recurrence. So how do you manage lamins? So, adenoma or the in situ, if you have a margin negative appendectomy, you're golden. Probably don't need to really do any further follow-up because these patients are essentially cured with that operation. T3 and T4, they do have a significant risk of future peritoneal dissemination, and so you have to at least follow them with serial imaging or and markers, and then if there's any abnormality, perform diagnostic laparoscopy.
So just to know for the lamins, so if you get a TIS lamin, you don't really see that very often. So we almost have no one in our database with a TIS lamin that you don't have to follow. Most of them are sort of T3, T4. They all have some kind of risk of recurrence in the future. So from a practical standpoint, most patients who have a lamin, you will have to follow for long term. How long? We don't actually know. We're working on that right now to try to figure that out because there's just very little data about it. So
if you didn't do the appendectomy and so you don't know the quality of the laparoscopy, will you do a laparoscopy on them?
So often we will. So two things that kind of come up from a practical standpoint. So number one is, is there any comment at all in the operative report about looking around or not looking around? And then when you stage them, is there any sign at all of mucin in the peritoneum? If there is any sign, then definitively we'll do a diagnostic laparoscopy usually 6 months or a year. If there's nothing and the patient is actually nothing on the CT, the patient is not super nervous and the markers are all normal, I will often forego the laparoscopy because it's such a slow growing process when it is a problem and just follow them serially with CT surveys. So it's a little bit variable in regards to that. But usually, if there's any question at all, those go.
All right, so now for the Hammonds. So essentially the same thing, except these have high-grade cytology confined to the appendix. Two-thirds of these, though, will develop recurrence, and so they do require surveillance following margin-negative appendectomy.
One thing about the Hammonds, we actually don't know what to do with those yet. So we have more than 2,000 patients in our appendix database, and we have like 60 or something like that, 50 or 60 Hammonds. So there's not a lot of data. We don't know exactly what to do. We generally treat them and talk about them as a Lammen with a slightly higher risk of recurrence. And that's the practical way to think about a Hammond until we know more about it.
So when the recurrence happens, is that Hammond again, or?
It's actually usually it's not usually listed as a Hammond when they get read out as cellular material in the future. It's usually either adenocarcinoma or low-grade adenocarcinoma or moderate-grade adenocarcinoma. Unusual to actually have that as a metastatic deposit.
All right, so then moving on to the adenocarcinomas, and there's kind of a differentiation here, well, no pun intended, of the well-differentiated and the moderately poorly differentiated ones, and how to handle those. So invasive neoplasms, looking at the mucinous adenocarcinomas, they're defined by infiltrative destructive invasion. They have high-grade cytological features, and they actually may have a mix of kind of both low and high-grade features, and that's actually kind of the more or fairly common. They may have signet ring cells components as well, and there's really a three-tiered grading scheme. And for these tumors, there's a lot of evidence that suggests that no matter how you grade them, that grade matters, and grade definitely correlates with survival. And so there's a lot of work from this institution and by some of our fellows that have really underscored that point about grading being important for these tumors. So why is there this kind of branch point? So, well, for the low-grade tumors, the well-differentiated tumors, these generally have greater than 95% gland formation, and the risk of lymph node metastases in these patients is pretty low. It's only about 5% or less than 5%. So with a well-differentiated carcinoma with margin-negative appendectomy, that's probably all you need to do at that time. For the moderately and poorly differentiated, though, you really have a significant chance of having lymph node metastases, and so you really have to follow that up with a right hemicolectomy for those patients. And then mucin matters sometimes. So the extent of mucin in these tumors. So for stages 1 through 3, really they're identical. So the outcomes for mucinous and non-mucinous adenocarcinomas are essentially the same. But where it matters is really when you have disseminated disease, and that kind of makes sense. I mean, if you have acellular mucin spread, that's probably not as biologically a bad thing as if you have a bunch of cancer cells spread throughout the peritoneum, and so that, at least to me, biologically makes sense.
That's a kind of an important point. So the first stage, 1 through 3, again, often people just think that because it's mucinous you have a better outcome. It's just simply not true. And for stage 4, if it's mucinous, it does matter a lot because the staging system that exists and previously existed is not very good. So, for instance, a patient who had a Lammen with acellular mucin on the final pathology of your resection, it'd be listed as a stage 4 disease. But in fact, a Lammen with stage 4 disease in this setting actually has a better outcome than probably a stage 1 or stage 2 adenocarcinoma. So it's a problem with the staging system more than anything else. But it's actually a really important point. You'll see more about. I think you talked about staging a little bit more as well.
So next question: a 6-year-old man is diagnosed with goblet cell carcinoid, or GCC, of the appendix after routine appendectomy for uncomplicated appendicitis. Biopsies indicate a T3 tumor of 0.75 centimeters with a negative proximal margin. Which of the following is the most appropriate recommendation? So A, no active treatment as prognosis is excellent. B, adjuvant hyperthermic intraperitoneal chemotherapy, HIPEC, without additional colon resection required. C, adjuvant long-acting somatostatin analog without additional surgery. D, right colectomy and adjuvant chemotherapy with a colon cancer regimen if disease is node positive. Or E, right colectomy and adjuvant therapy with a somatostatin if disease is node positive. Thwarted. Yes. All right. Moving on to, so the goblet cell tumors I kind of already talked a little bit about, but really, it's kind of this spectrum of the in-between. So these tumors have, a component of neuroendocrine differentiation and a component of adenocarcinoma. So, depending on the extent of kind of adenocarcinoma features, they really behave more like colon cancer, like adenocarcinoma. And so for these tumors, in general, you need a right hemicolectomy and systemic chemotherapy for lymph node positive disease.
The main thing about these tumors is they're not carcinoid in any way. It's a misnomer. In fact, you shouldn't even call them a goblet cell carcinoid. It should just be a goblet cell tumor. They really don't behave like a carcinoid. You shouldn't think about like a carcinoid. If they have it, they have a right colectomy, and that's all. And treat with chemotherapy if lymph nodes positive. The other quirk about these types of tumors is they interestingly can represent or have metastasis late, like years later. Don't know why exactly it is, but a number of patients who kind of did well for years, and then 5 or 6 years later they develop peritoneal metastasis. Strange sort of quirk about these tumors.
So next question. A 48-year-old female undergoes uneventful laparoscopic appendectomy for acute appendicitis. Pathology reveals a 1.8 centimeter low-grade carcinoid cell tumor of the appendix without lymphovascular invasion. There is no invasion of the mesoappendix, and the appendiceal stump is margin negative. Which of the following is the most appropriate management of this patient? A, cecectomy and lymphadenectomy. Ileocolectomy with resection of 10 centimeters of ileum and right colon. Adjuvant octreotide, right hemicolectomy, or surveillance only. Right. Okay, so looking at the carcinoid tumors, I mean, I think this has been it's a typical ABSCII question, so I'm sure we have experience with this. But the ENET's consensus guidelines for neuroendocrine tumors of the appendix, appendectomy alone is adequate for negative margins, size less than 2 centimeters, and no unfavorable characteristics. You would need to proceed to a right hemicolectomy if you have positive margins, the tumor is larger than 2 centimeters, or there are unfavorable characteristics like mesoappendiceal invasion, or it's higher grade, or there's angioinvasion.
So just a quick thing about these tumors. You would think that everyone would have this figured out, except that in the last week I've had 2 people who were practicing ask me about this question, about what to do with a carcinoid was under 2 centimeters. So you'll see it all the time in practice, and so you should kind of know this. The other thing is that for the unfavorable characteristics, it would be a really great research project for somebody to look into this, because there is very little good data about this. A lot of people, I often don't, even when I have some of these things, I often don't offer a right colectomy. Certainly if they're sort of over middle age, I usually don't, unless it's a high Ki-67, but the angioinvasion and all that, there's just not good data.
So I have a paper into cancer that's a predictive model of lymph node metastases based on the NCDV on this pathology, and it's a thing you can input the characteristics, and it spits out the percentage of lymph node metastases on ones who've had right hemicolectomies.
And what it says from the NCD?
NCDV, yeah.
Right. So that's good.
Yeah.
Better to have like to be completely honest, a big database from a sort of a single institution that talks the same language with their pathology. You know what I mean? But it's more applicable to the general population with the way you kind of have done that. So what do you think about those 3 unfavorable characteristics?
So the Ki-67 definitely. The mesoappendiceal invasion did not bear out,
Yep.
and the angioinvasion, there really weren't enough that were called to make a difference.
So that's exactly how I handle these patients. So KI67, if they have it, then we get it. The other two, generally I don't, unless it's a really young patient, because I'm just afraid. I'm a pussy. So, all right.
All right. Next question. A 40-year-old woman has an open appendectomy for appendiceal mass. Final pathological evaluation indicates a 3 centimeter well differentiated neuroendocrine carcinoid tumor of the appendix with negative margins. Recent CT shows no evidence of disease. Which of the following is the next most appropriate step? So no further treatment or surveillance is indicated. Surveillance with imaging, systemic chemotherapy, or right hemicolectomy, or right hemicolectomy and systemic chemotherapy. All right. Jump to the next question. All right. Wow. A 40-year-old otherwise healthy man had a laparoscopic appendectomy 4 weeks ago. His recovery is uneventful, and he has no symptoms. Mucin was seen in the pelvis during the operation, and biopsy specimens were obtained from several omental mucinous implants. Biopsy indicates a ruptured appendiceal, well-differentiated mucinous adenocarcinoma with a negative proximal margin. Examination of the mucinous implants confirms adenocarcinoma without signet ring cells. CT of the chest, abdomen, pelvis is normal. Which of the following is the most appropriate recommendation? So you can A, observe and treat when they progress. Systemic chemotherapy with 5-FU with surgery consideration for palliation if symptoms develop. Right colectomy with excision of associated mesentery and omentum followed by systemic 5-FU. Right colectomy with excision of associated mesentery, cytoreduction, and HIPEC, or placement of peritoneal catheter for combined systemic and intraperitoneal administration of chemotherapy. All right, so the answer is D.
Minus the right colectomy.
yeah, so F should be the real answer. None of the above.
So you wouldn't start with neoadjuvant chemo. Well, not neoadjuvant.
No, so anytime it's well differentiated, there's almost zero benefit to systemic therapy for well differentiated tumors. So we're not doing any neoadjuvant therapy. So well differentiated appendiceal adenocarcinoma is a surgical disease for a patient who can undergo surgery.
All right, so sorry about the orientation of this, but
Did you get into why none of the above is
Yeah.
the answer on that question?
Yeah, so
with a negative margin for well diff, like you don't need to do a right colectomy, the odds of it metastasizing to the node is next to none.
and actually also not prognostic, right?
Did you-
So even in the patients who have node positive disease in the setting of metastatic disease, there's no utility to doing a formal right colectomy. Now, if there is disease on the colon or the junction or on the outside or whatever, of course you need to clear the disease. But for a lymph node harvesting for evaluation of either sort of progression in the future or prognostication, definitely not.
When you say for metastatic disease in this case, you mean like peritoneal mucin?
Yeah, what else? What other kind of disease do these people get?
Now, if they biopsied that mucin and it was acellular, would you need to find information about the lymph node status, or?
No. So go back to your question about metastasis. So if this is a low-grade tumor, it doesn't go anywhere else, right? So low-grade adenocarcinoma is exceedingly uncommon to go anywhere. Lymph nodes, liver, sometimes will go to the lung, but usually that's a function of the diaphragm having been violated at some point after a CRS and HIPEC. So very, very uncommon. It's not impossible, but exceedingly uncommon. And acellular mucin, the real question that you should ask is, do you need to do anything? So if a patient has a low-grade adenocarcinoma of the appendix, and you look around the peritoneal cavity and you remove some stuff, and it's all acellular mucin, did you need to do anything at all? We don't know. We're just right now looking at our series of patients who had just acellular mucin. Not a single person has recurred after HIPEC, which probably means they didn't need the HIPEC. But the problem is, of course, how do you know that until you remove all the tumor, right? Until it's in the bucket and the pathologist have told you that there's no cellular material. So that's a little bit of a gray area. But those folks, and it leads into another thing, is that the current AJCC staging system links that metastatic disease with acellular mucin the same as a low-grade adenocarcinoma in terms of metastatic lesions, and it's clearly a significant difference, right? So overall survival 10 years for low-grade adenocarcinoma with adenocarcinoma peritoneal deposits is greater than 70%, but again, acellular mucin, it's 100%. So that needs to be separated out. The staging system is not correct. Hopefully in the next iteration we can fix that.
So because this is mucinous adenocarcinoma, the answer is CRS basically.
Yes.
And then if it was acellular, it would be A. It would be observation.
I can't say that for sure.
Okay.
You know, we can't say that for sure. But the outcome is phenomenal, right?
Okay.
So it's the other thing that finding out this information will be helpful for is you know the interval of surveillance. So right now we have these patients that we see every whatever 6 months or whatever with acellular mucin. If we find that in fact final pathology is all acellular mucin, then we can potentially not survey for ever. So after the surgery, you might say you're basically cured of your disease without the need for every 6 months CT scans, tumor markers, trips to wherever you go to get that done. So it's a really important question.
So the reason why A is you say you can't be sure is because you don't crystal ball to know that it is all acellular
Right.
mucin. That's the main thing.
Correct. Yeah. Until it's all in the bucket, there's no way to know for sure.
All right, so this is a yeah, exactly. So this is just the kind of a timeline, of the progression of cytoreductive surgery. Evidence back into the early 20th century indicating that cytoreductive surgery for ovarian cancer was beneficial, and then with the advent of kind of more sophisticated, or actually I like to think of all chemotherapy is very unsophisticated, but of chemotherapy and developing kind of methods for delivering chemotherapy within the peritoneum, kind of in the 1970s, and then with kind of really the pushing the envelope and starting to do HIPEC as we know it today, more in the 80s, refining the characteristics in the 90s, and in the 2000s, kind of figuring out with patient selection. And so really, it's kind of been a long road for the development of this type of surgical technique. So cytoreduction, the goal is systemic exploration of the peritoneal cavity, and then to calculate the volume of the tumor present. You do this with the peritoneal carcinoma index, and so you'll see when you rotate on PM1 or 2, you'll literally make the tic-tac-toe box and score every segment of the abdomen, as well as so you have the 1, 2, 3, 4, 5, 6, 7, 8, kind of in a clockwise fashion, and then 0 is in the middle. You score those, giving them a lesion size score. So if there's no tumor seen, it's 0. If there's a tumor that's less than or up to half a centimeter, it's 1. If there's a tumor up from up to 5 centimeters, it's 2. And then if you have tumor that's greater than 5 centimeters, or if there's confluent disease, then you give it a score of 3. And you do this for each one of the boxes. You also score the entire small bowel with essentially the proximal jejunum, distal jejunum, proximal ileum, distal ileum in the same manner. And then you come up with a score of basically from 0 to 39. You can also predict resectability using radiographic imaging, and this was developed here by Dr. Fournier, the SPAT score, in which you look at the CT scan, you assign a point each for imaging evidence of scalloping on the liver, the spleen, pancreas, or the portal vein. And then you assign 3 points for this cauliflowering or foreshortening of the small bowel mesentery. And you can have a total score of 0 to 7. And then a score less than 3 is a significant predictor for the ability to achieve complete cytoreduction. And so as you can see here, you got the scalloping um, characteristics there on those organs. And you'll see Dr. Fournier, he'll teach you how to do this kind of in a systematic way, essentially going clockwise. And you look at the liver, you look over the stomach and the spleen, kind of and then around into the portal, around the portal vein. And then you look at the small bowel mesentery. You can see this really is kind of foreshortened mesentery and the cauliflowering appearance, and that's what you'd assign 3 points for. So cytoreductive surgery, essentially is the treatment of macroscopic disease. And you do a total omentectomy, peritonectomy of the involved surfaces, and then resection of the involved organs, whether it's gallbladder, spleen, the colon, the uterus and ovaries and tubes, small bowel that's involved. And then also, something that's been developed to really kind of be able to really communicate the completeness of the cytoreduction. It's been to assign a score, 0 if there's no visible residual tumor, 1 if tumor is less than 2.5 millimeters, from 2.5 millimeters to 2.5 centimeters, it's 2, and then anything bigger is 3. So that way you can essentially compare and know what has been done.
One thing to know about the completeness of cytoreduction score, it's actually been shown that pretty much in every disease that we treat with CRS and HIPEC is one of the most important prognostic indicators. So whereas for PCI, it's mostly important for sort of colon or high-grade appendix, not so important for low-grade. CCR score for just about every disease is prognostic.
And the other score, SPAT, do you use that to make the decision whether to operate or not?
So not really. So what I use it for, or what we use it for, is the discussion really with the patient, right? So if you have that SPAT score basically, and it's less than 3, there's a 96% chance that you will get a complete cytoreduction, right? If it's greater than that, my conversation changes with the patient. My conversation with the patient is there is a much less likely ability for me to get it all out. However, we still can offer so-called palliative HIPEC with sort of an organ-sparing approach. So it's mostly so that you can educate the patient ahead of time. Because that's extremely important, is patient education and sort of what their expectation is for the result. And so that's what it's been really helpful for, is to kind of temper your talk with the patient.
And the palliative HIPEC is to limit the mucin production.
A number of things. So James Lindbergh just looked at our outcomes for palliative HIPEC and found that yes, close to 90% of the time, ascites is controlled with the HIPEC, but actually our overall survival for, at least for the low-grade tumors, even in the palliative setting, is 7 years, right? So they actually gain significant improvement in overall survival. So it's mainly this is mainly a tool for talking to patients.
Both the last two.
Doctor, if the score is 1, can I consider the status as NED? If the score is 1, can I consider the status
Well, this is
as NED?
pre-op, so no. So this is a pre-operative scale. So the CCR, maybe you're talking about the CCR?
Yeah.
So it's still considered a complete cytoreduction at the end of the operation. So a 0 or a 1 is considered complete because the size of the lesion is less than 2 millimeters, and allegedly the chemotherapy can penetrate that.
So that's where, good segue, intraperitoneal chemotherapy. This is for the treatment of microscopic disease. So you've taken out everything that you can see, and this is for the stuff that is still floating around you can't see with the naked eye. So you can essentially obtain much higher intraperitoneal concentrations of the chemotherapy by direct application. The tissue penetration is by diffusion and convection, and then you have 2 options. The HIPEC, which is essentially at the time of the cytoreductive surgery, or EPIC, which is early post-op after the cytoreduction. So for HIPEC, generally there are a whole host of agents that can be used. In general, these are the main ones used here. So mitomycin C for appendiceal carcinomatosis, cisplatin for mesothelioma, and oxaliplatin for colon. And the hyperthermia, it's generally 41 to 42 degrees, and it really, one of the things we're looking at is kind of the timing of it, because there's a whole range of times that can be done. So from 30 minutes to 120 minutes or more. And so the thought is that the hyperthermia increases perfusion and oxygenation, that increases drug penetration, and that there's inherent cytotoxicity of the hyperthermia itself. And you can see here there are a number of studies that kind of show that hyperthermia, delays tumor growth, increases tumor penetration, and has essentially improves overall survival. So here's the HIPEC basic setup as it's done here. So you have the inflow cannula going up above. That generally kind of is bidirectional, so it goes into the right upper quadrant and the left upper quadrant. And then the outflow cannulas are down below. You have this kind of like a fenestrated cylinder that allows for fluid to come into it, and then you have the outflow suction cannulas and the overflow cannula, the smaller overflow cannula next to it, and to cycle the chemotherapy. So you need a perfusionist and a perfusion system with a heater and a pump. The flow rate, you need a minimum of 800 milliliters per minute. You really want about 1 to 1.5. And you need some mixing to have kind of equal distribution. So that's where the shaking comes in. Some pre-op considerations. So this operation and procedure definitely takes a toll on patients, and so you have to look at the patient biology, the nutritional status. Anything less than 3, you have to really proceed with caution. Age is kind of a soft consideration, but something you should be aware of. Performance status, the comorbidities, and their understanding of their current situation, kind of what cytoreduction HIPEC is and what it will achieve for them. And so that's what Dr. Fournier was talking about earlier, about having those discussions ahead of time with the patient about expectations.
And they all pretty much come in thinking that HIPEC is this magic wand that's going to fix everything, and you just got to be very clear to them what you can expect to gain by doing this, because it's a pretty morbid operation with a long recovery back to baseline.
And so post-operatively, it's not uncommon for patients to have low-grade fevers within the first week or so. They are all going to have electrolyte abnormalities. Oh, and so that's especially in the first couple of days, that's something you really have to pay attention to, because they will have some severe electrolyte derangements. Especially for oxaliplatin, they're gonna have these are very nephrotoxic agents, and so even though that they are making good urine, they will diurese, and so their urine output has to be exceptionally high, and you have to keep them very well hydrated, just because 30 cc's an hour is not adequate for these patients. And so they're all going to have an ileus, or a lot of them will, almost without exception. High median number of stools per day, so they'll have some diarrhea, and then usually around the first, especially with mitomycin C, you can get this profound neutropenia, and you can also get thrombocytopenia and just pancytopenias. So what can the patient expect? The operation really kind of varies in duration, obviously, but it's about it's a long operation. There is a significant, it is a morbid operation, so there are complications. patients tend to stay a little longer in the hospital than kind of most of our ERAS patients on other services. There's no ERAS for
It
HIPEC.
doesn't work.
Yeah. And then, there is this kind of there's a dip in their quality of life and their functional status, and they will require serial surveillance, every 4 to 6 months, for the foreseeable future. And so, question: 60-year-old female with low-grade mucinous appendiceal neoplasm is offered cytoreduction hyperthermic or HIPEC. She states she has read about early postoperative intraperitoneal chemotherapy. Which of the following statements is true when comparing HIPEC to EPIC? So A, both therapies utilize heat. B, both therapies are administered in the operating room. C, both therapies can result in neutropenia. D, both therapies have level 1 data to show benefit for their use. Or E, both therapies take the same amount of time for administration completion of treatment.
C.
Yeah, so they can both give you neutropenia. So HIPEC-induced complications, like I mentioned, the pancytopenia. Something I didn't mention was that they can definitely have poor wound healing, so we'll often leave staples a lot longer. We're a lot more careful about essentially wound healing in general. And then I mentioned the renal insufficiency, which is a big concern. Next question: a 40-year-old otherwise healthy man has a symptomatic right inguinal hernia. He has a history of increased abdominal girth and early satiety over the past 12 months. The patient's weight is stable and he demonstrates excellent exercise tolerance. Upper and lower endoscopies are normal. CT of the abdomen and pelvis demonstrated a large appendix and ascites. Percutaneous biopsies indicate abundant mucin and scant cellularity. Which of the following is the most appropriate next step? A, open peritoneal biopsy with mesh repair. B, percutaneous drainage of ascites and right colectomy. C, repair of inguinal hernia with mesh and repeat CT in 6 months. Or D, exploration with histologic confirmation followed by cytoreduction and intraperitoneal chemotherapy. Or E, 6 months of systemic chemotherapy with those agents, FOLFOX, and biologic agent and repeat CT. Right.
So you laugh and you make that statement, but several times a year, someone comes in with that exact same thing, and then they get mesh all stuck in the mesh. There's mucin all stuck in the mesh. It's unbelievable what happens out. It's unbelievable.
They'll usually just present with a hernia without a scan, and they'll go in and do the hernia.
Yeah, yeah. And of course, I got the hernia. So, oh, my doctor got the hernia done, but he found out, he found out this thing. How pleased that he did the hernia, and it's just crazy. I mean, it's just totally fix it. It's crazy.
Would you ever consider cytoreduction without HIPEC, or is there an indication when to do that?
Sometimes do.
It seems like people do that, but I don't really know what the indications for one.
So for appendix cancer, I would generally, certainly for low grade, I would generally use HIPEC. That definitely seems to help because the HIPEC part of this procedure really seems to control the ascites. Even if you can't get all of the disease out, it really controls the ascites. So I think as a general rule, I would do HIPEC. Now, if you have somebody who has some liver disease or hepatitis, so I've had a couple patients with Hep C and things like that. This was kind of sort of before treatment for hepatitis C, but I would not do the hyperthermic part. I do normal thermic perfusion because patients seem to tolerate that better, and you don't have so much toxicity related to the liver.
I was thinking more just not doing any type of intraperitoneal therapy.
Yeah, so generally not for low grade appendix. For other types, so for colon, you'll get to that if we have time. For colon, often we'll do that. Yeah.
Sorry, I didn't know you were talking.
No, that's cool.
I thought I saw a blank side.
Yeah, so I'm gonna try to cover this in the next 5 minutes. So, for low-grade appendiceal mucinous neoplasms with peritoneal disease, that's an indication. As you can see, there's a high risk of peritoneal dissemination in T3, T4, and then these patients are generally followed. So, best available data for low-grade appendix cancer. So, this is data from this institution. 55 patients received cytoreductive surgery alone, and you can see their 5-year survival there. And then with cytoreductive surgery and HIPEC, you can see vast improvement. So definitely for low-grade appendiceal cancer. I'll skip the question.
Don't rush, Jeff. I mean, you guys started late.
Okay.
Leave if you want to leave. It's fine.
All right.
We feel it.
All right. So no one saw the answer. A cytoreduction in hyperthermic intraperitoneal chemotherapy perfusion has just been performed on a woman with an appendiceal mucinous neoplasm and pseudomyxoma peritonei. Despite a considerable disease burden, a resection is performed with a complete cytoreduction score of 0. The final pathologic evaluation indicates a low-grade mucinous neoplasm with 20 negative lymph nodes in the right hemicolectomy specimen. The patient recovers well after the operation, goes home in 3 days. Which of the following is the most appropriate follow-up care for this patient? And the answer is, yeah, a surveillance.
Just to highlight the important thing about that is, again, no chemotherapy. Low-grade adenocarcinoma of the appendix is a surgical disease. Surgical disease. Surgical disease. We see all the time patients are coming in, they got chemotherapy for 6 months, 12 months, 2 years. Doc, I've been on chemo for 2 years and I'm doing great. Cancer's not progressing. Yeah, no shit, because you didn't need it. we have a trial, open randomized controlled trial for patients who are not surgical candidates or who just refuse surgery, comparing systemic chemotherapy to nothing, and they actually they get 6 months of chemo and 6 months of internal control. We haven't accrued many patients, as you might understand, because it's a surgical disease, but we've seen no benefit at all.
So my apologies for this, but this is essentially the algorithm, our algorithm for treating patients with well-differentiated low-grade mucinous adenocarcinoma of the appendix. So the first is, you do essentially the staging and the review. If there's no residual disease after a appendectomy with essentially margin negative, no residual disease, imaging is normal, tumor markers is normal, and the colonoscopy is normal, then you just simply follow them. Essentially every 6 months for 2 years with tumor markers and imaging. And if the tumor markers and the imaging after 2 years, no evidence of recurrent disease, then you can just go annually after that. Then if there's margin positive or there are elevated tumor markers, then you can do a diagnostic laparoscopy. If there's no peritoneal disease, you do a right colectomy if there's the margins are positive, and then kind of get back onto this track. If there's biopsy-proven peritoneal disease and or large volume of peritoneal mucin, then you assess for cytoreductive surgery in HIPEC. And then on this over here, if there's known peritoneal dissemination, then you assess them for HIPEC.
Jeff, real quick, did I just hear you? I can't.
Yeah, no, it's there. Sorry.
No, it's okay. Did I just hear you say that elevated tumor markers, negative laparoscopy, right hemicolectomy?
I'm sorry for.
Is that what I just heard?
No, so these are elevated tumor markers, diagnostic laparoscopy. If there's no peritoneal disease, then you do the right colectomy. If the margins were positive on the initial.
Oh, I didn't hear the margin.
Yeah.
I heard it was just.
No,
the
yeah,
elevated
just
tumor markers,
no,
like,
yeah, margin
You'll
colectomy.
do an ileocephectomy for those people, right? You don't do right colectomies.
No, just clear the disease.
Yeah,
Right?
you just get a negative margin.
Negative margins on
Your tumor markers are CA, CA19-9, 125.
All right. A 50-year-old woman has surgical exploration for presumed ovarian cancer. Findings include tumor arising from the cecum, involving the right ovary, right pelvic sidewall, uterus, subdiaphragmatic peritoneal surfaces, and extensive small bowel serosal surfaces. There is no evidence of obstruction or bleeding. Evaluation of frozen section specimen from a peritoneal implant indicates high-grade adenocarcinoma with signet ring features. The patient has an excellent performance status and noted before the surgery that she wants you to do everything. She wants everything aggressive. What's the next step in the treatment? A, administer HIPEC, limited cytoreduction to minimize morbidity. Administer HIPEC with complete cytoreduction. Perform cecectomy. Stop the operation. Refer the patient for whole abdomen radiation therapy. Or stop the operation and refer the patient for systemic chemotherapy. Yeah. So this is bad news. Stop the operation, refer for systemic chemotherapy. So moderate and high grade appendix cancer, like I just mentioned, it's bad news compared to low-grade disease. So at MD Anderson, the patient selection criteria for moderate and high-grade for proceeding with HIPEC in patients with this type of disease, they can't be old and frail. Their PCI has to be manageable. There's mandatory diagnostic laparoscopy to evaluate that. Disease, so they have to be on systemic chemotherapy, and there has to be stability of disease, or they can't be progression of disease. There's got to be no extra-abdominal disease, no lymph node involvement, and no need for extended liver resections. And also, you can't have someone that you're going to leave with potentially short gut or significant bowel involvement. So generally, kind of patients who have low level of disease and have been stable or have a good response to chemotherapy and have good performance status and they're young. Again, apologies, but this is the algorithm here, essentially saying the same thing. So the outcomes for CRS HIPEC for appendiceal primaries. So, overall survival is pretty good in all these series. Morbidity is kind of probably what you'd expect, and the vast majority of these have a pretty good cytoreduction. Question: a 60-year-old woman has cytoreduction for all macroscopic tumor of a mucinous adenocarcinoma with extensive involvement of the peritoneal surface, and HIPEC with mitomycin C administered by open technique. Which of the following represents the most common postoperative complication associated with the surgery? What's the most common? A, prolonged ileus with or without evidence of pancreatitis, renal insufficiency that could be prevented with sodium thiosulfate administration, renal insufficiency due to hyperthermia that is self-limited and reverses on its own after 24 to 36 hours, intraoperative hyperglycemia, and severe electrolyte imbalances due to mitomycin C diluent, or temporary decreased WBC from chemotherapy-induced bone marrow suppression. Anybody? Yeah, so I mean, like I mentioned, they will all have an ileus post-op. So
the sodium thiosulfate, that's for cisplatin, right?
For the platinum agent.
You give that for people who get HIPEC with cisplatin for gastric therapy.
How comes the decrease in white blood cell?
So they all get myelosuppression. So they especially with mitomycin C, so they'll about a week out you can see a dip in their white blood cell count.
So all of them.
Almost, yeah. You can get it with all of them, but especially with mitomycin C.
Probably around 10% need something done about it. To give them nitrogen, something like that.
So what do they get? They get ileus, like I mentioned, wound complications. So if you do the diaphragmatic stripping, you will almost undoubtedly get a pleural effusion, and that's why here we put chest tubes on the side. They'll get neutropenia, renal insufficiency. You always worry about anastomotic leaks or abscess, pancreatic leaks, and then need for take-back. So this is.
Just highlight our mortality is 0.8%, not 0.5% common.
What's that?
Our mortality is 0.8%.
Yeah, and that's 0.04. I'm sorry. 0.04.
Once you're here for a little while, you'll be able to say these numbers for every service. Exactly the same.
So I think one of the major points of the talk should be that this is a morbid procedure, and there has to be good preoperative counseling. So this is a study looking at kind of a functional status. Am I getting more already? Okay. So it's basically what this says is that they'll have a dip in their functional status. They'll feel like crap for about 3 months, and then they'll kind of recover to baseline. But that is part of the patient education preoperatively is that they are going to have this dip in their overall baseline functional status.
The important thing about that is to actually highlight that preoperatively, that it will take them 6 to 12 months to get back to baseline, because invariably every patient thinks they're gonna be Superman out of the hospital in 5 days, and that they're gonna be back doing everything they want to do in 3 weeks. Every patient thinks that, so you just got to reiterate it multiple times to make sure that they truly, or do your best you can to make sure they truly understand that fact.
I think the other thing that you always highlight is the rate of complication, and that, 50% of people are gonna have some sort of complication. And people hear that, right? And so it's not like a surprise to your patients when they're in the hospital for 10 to 14 days.
This is not an operation that you oversell in any way. Not that you should ever oversell any operation, but you got to be super honest and upfront about exactly what's going to happen to these people, because it happens to every one of them.
So, as with any kind of major, technically challenging operation, that there's going to be a learning curve, and certainly this series illustrates that there's improved survival after 130 cases, that there's also decreased complications after doing a fair number of these, and so there is this built-in institutional learning curve. 60-year-old woman undergoes cytoreduction in HIPEC for peritoneal carcinomatosis from colorectal cancer. She had colon and small bowel resections with anastomosis, peritoneal stripping of the right diaphragm, omentectomy, splenectomy, and bilateral salpingo-oophorectomy. Which complication is least likely? Pleural effusion, post-op bleeding requiring reoperation, prolonged ileus, pancreas fistula, or anastomotic leak? Yeah. So everything else is likely. This is the less likely.
The one reason I put that, I would just tell you the reason why they put that here is they may think that some people have a little bit of familiarity. In Europe, where they use oxaliplatin doses of 400 milligrams per meter squared, we use 200 milligrams per meter squared. One of their common complications is hemoperitoneum. So I think that's where this question comes from. It's known side effect of high doses of oxaliplatin.
It's like burning blood vessels.
Not sure why exactly it happens.
Is it like post-operative HIPEC, but it's hypothermic bleeding? It's just like
put the chemo back into the
just run back in.
Now we're gonna bathe you inside with blood.
If they can put it together.
So for colon cancer, so this is kind of one of the major findings at SSO this year, was kind of how this relates to colon cancer. So it's a significant burden of disease. About 13% of these patients will develop peritoneal metastases, and HIPEC has been proposed as an effective strategy. But when we talk about this, we do have to put it in the context of kind of more contemporary chemotherapy. Colon cancer obviously has been treated for a long time, and the chemotherapies have changed quite a bit, and essentially survival now is much better with our current agents than they were even kind of in the more recent past. But when you look at peritoneal carcinomatosis, the prognosis is pretty poor. You can see here that the overall survival is much worse with peritoneal disease. And also, what's really interesting is that peritoneal disease is different. So essentially the molecular and genetic profiles of these tumors tend to be different than what you would see in, for example, hepatic metastases. Why is there a resistance to systemic chemotherapy? Well, these peritoneal nodules tend to be small and are generally poorly perfused. They have elevated interstitial fluid pressure, and they're a hypoxic tumor environment. So when you compare cytoreductive surgery HIPEC versus systemic chemotherapy, there is some benefit to the CRS HIPEC versus systemic chemotherapy. How much of that is the CRS and versus the HIPEC, we'll see in just a second. But then there's also this series where they had 48 patients who received systemic chemotherapy that were actually candidates for the cytoreductive surgery in HIPEC, but for whatever reason, logistical reasons, they prevented from having that. And again, you can see that HIPEC and cytoreduction um, had improved survival. Skip that. So here's our data from MD Anderson using CRS HIPEC for colorectal cancer. 52 consecutive patients with colon cancer and peritoneal dissemination of disease who underwent CRS and HIPEC used oxaliplatin for 60 minutes and looked at disease-specific survival and saw that overall it was about 55 months. And then a lot of it, you can see here that if you get good cytoreduction, it's a lot better than if you don't. And also if you have, high grade versus moderate grade, that also makes a difference. Which leads us to the Prodigy 7 trial, which is a multi-center randomized phase 3 trial comparing cytoreduction alone to cytoreduction for HIPEC and HIPEC for colorectal peritoneal carcinomatosis. So they're randomized 1-to-1. They stratified by center. They had 17 different centers. They also stratified by completeness of resection and neoadjuvant therapy. And then the primary endpoint was overall survival, and secondary endpoints were what is it, RFS? Help me out. Okay, there we go. Sorry, blanked, and toxicity. So they had 265 patients. The arms were equal. The median age was 60. It was pretty well balanced. So the take-home points are there's no difference in overall post-op mortality. There's no difference in morbidity at 30 days. The higher grade there was higher grade 3-5 morbidity in HIPEC at 60 days. And then after a median of 64 months, the overall survival was essentially the same. And the median recurrence-free survival was 11.1 months for those without HIPEC versus 13.1 months with HIPEC. So really not much different and a little more morbid to receive the HIPEC. And so here you can see the survival curves essentially kind of traced over each other. The median survival the same. And then when you do the subset analysis, though, you can see that there are some patients that do benefit from the HIPEC. You can see that over here, the patients with the PCI 11 to 15 seem to have a better survival when you perform the HIPEC or not, versus people that didn't. And that kind of makes sense. If you have disease that is terrible, I don't think probably no matter what you do, it's going to be bad. So the outcome's not going to be any different. And then if you have disease that's very small amount of disease, and you essentially do the cytoreduction, you're going to do well kind of regardless. But there's this middle, essentially block of people who have moderate disease that you cytoreduce, and then you clean up what's left with the chemotherapy, and there may be a difference, or it looks like there is a difference for those patients. So for those patients that have colorectal cancer, peritoneal carcinomatosis, I think there's certainly an argument that you could offer HIPEC for those patients.
So I want to ask you something about this, and maybe this is what you were going to get at, but I've heard you say to people, like, your quality of life is affected for 6 months, reduced for 6 months. That's a 9-month difference in survival. So are you, or are we as an institution, right, is this something that we're still going to pursue?
So right now we're doing that 11 to 15 range only. So we do, and part of it has to do with our outcomes, right? Our own institutional outcomes is better than this by a fair amount, actually. Our overall survival is more than 60 months, right? And so I feel okay making the case to do it, but I don't do it for low volume disease. And it makes sense, right? You think low volume disease is truly just a local failure, probably, right? And then high volume disease is just a failure of everything. They're not going to do well no matter what you do. But that mid-range is kind of maybe a field defect in some way that some of the peritoneal cavity is involved, and it makes sense to consider doing this. Some other important points about this, though, actually, is that all these email chains of people who do all of this, and you should, everyone was in an uproar about this because we were saying, some of us were saying we shouldn't be doing it and all of this, and people just kind of freaked out about it. But it does highlight a couple of things. Number one is maybe oxaliplatin isn't the right drug. Maybe the time, because we don't know the interval they used. I mean, the length of HIPEC they used 30 minutes, right? Versus 60 versus 90 versus 120. Doses. I mean, there's a lot of things that kind of go into this, but it could just be that it doesn't work. It just could be that it doesn't work. Another important point of this is that we've often thought about trying to find patients who are at highest risk of failure and could prophylactic HIPEC be beneficial. This probably suggests that it is not beneficial, right? So somebody who has a woman who has ovarian metastasis at the time of her colon surgery, you take out the colon and the ovarian metastasis, she's considered high risk. But this data would suggest that HIPEC is not going to be helpful for prophylaxis. There's a number of trials open right now. There's at least 3 trials that are looking at this. But I strongly suspect that we'll find that it really probably doesn't work.
Are you basing the decision on radiographic PCI or surgical PCI?
Surgical PCI. Okay. So when I talk to the patients, I tell them if it's low volume, you get no HIPEC. If it's moderate, you do it. Usually, I do a laparoscopy on every patient before I do HIPEC, so I have a very good understanding of what their disease burden is. Rare does we change from the time I give my laparoscopy to the time I do surgery.
So another indication for HIPEC is peritoneal mesothelioma. This is an extremely rare disease, but I think probably most of us have seen at least one case on our rotation with you. So the rare disease is not so rare here. So there is a link to asbestos exposure. There's a latency period, just like in pulmonary. There seems to be a closer relationship with males in terms of asbestos exposure. And this is one of the diseases where kind of the subtype really matters. So for the sarcomatoid, it's just bad. They just go to systemic chemo and the outcomes are not good. Biphasic, it's essentially kind of a case by case. And then really the favorable ones are the epithelioid, and the really favorable one is the papillary. And you can see the best available data for mesothelioma with just traditional therapy, not so good. And then with CRS and HIPEC, it's better. It's pretty good. There is kind of an overrepresentation here of some of the kind of more favorable subtypes.
So just to tell you that, so this is our data RAGOV right here. So for the 78 months, that's epithelioid for all comers with epithelioid, some with papillary, etc. was 201 months. So it's definitely.
And then I think this was mentioned earlier. You can also use it as a palliation for ascites. I think once you see someone who's like a redo HIPEC, you can definitely see kind of one of the things that this therapy does is it definitely kind of locks things in place. Like there's a lot of scar formation, a lot of adhesions that are formed, and it seems to really kind of dry up the milieu within the peritoneum. And that's one of the benefits, especially with these tumors that create a lot of ascites. This is another paper just showing kind of the positive prognostic factors. These are from Australia. And then here's our algorithm for managing mesothelioma, peritoneal mesothelioma. And really, it's just kind of what we talked about already. It really depends on the subtype and whether they're if they're really favorable subtype, you can move to cytoreduction and HIPEC. If they're a bad subtype, really just go to chemotherapy and see what the response is, and then can consider later. And then the kind of the middle of the road subtype, it kind of depends on the burden of disease, whether you proceed with HIPEC.
We just sort of changed it. Previously, for patients who were coming in with potentially resectable disease, epithelioid subtype, we were doing CRS and HIPEC kind of up front, and and over the last year, we've kind of changed that a little bit, trying to identify patients who may benefit more from neoadjuvant approach, so we're using the CT-PCI. So I can't give you any good data on that yet. Hopefully within the next year we'll have some data on that.
And then some more outcomes after, this is for repeat cytoreductive surgery in HIPEC for mesothelioma. When you can still, some of these series, you can still get a pretty good cytoreduction, and the overall survival is still decent for repeat operations. So, what are the accepted indications for HIPEC? Definitely for appendix. Mesothelioma, certainly the more favorable subtypes. And then for colon carcinomatosis, I should have actually modified this. This really is for PCI 11 to 15 now. Role in sarcoma, I think you're going to see a lot of this in the literature. There has been data here in the last year or so that seems to suggest that there is not, especially for desmoplastic round cell. The role in gastric cancer is currently being studied here as well, and there's some emerging data for its use in ovarian cancer as well. And so, conclusion, pathology. The pathology is a big determinant. The impact of cytoreduction is also important. The higher the grade of the tumor, the more important the PCI, and then the impact of the package of cytoreductive surgery in HIPEC is, well, at the time before, at the time before the Prodigy 7 wasn't entirely clear for colon cancer, but it's now becoming more clear. So last question, 55-year-old man has laparoscopic appendectomy for acute appendicitis. During the operation, a contained rupture of the tip of the appendix is found. Gelatinous society's fluid is evacuated from the abdomen pelvis. Pathological evaluation indicates a 3-centimeter low-grade mucinous neoplasm obstructing the lumen of the base of the appendix with perforation of the tip. All margins of the resection are negative, and there is no invasion of the mesoappendix. Cytologic analysis of the mucinous fluid demonstrates extensive acellular mucin with scant low-grade mucinous cells. Which of the following statement about this type of neoplasm is correct? A. Epithelial neoplasms of the appendix are found incidentally in 1 to 5% of appendectomy specimens. A right hemiplectomy should have been performed at the time of surgery. Cytoreductive surgery and HIPEC should be considered for this patient, or cytoreductive surgery and HIPEC are associated with morbidity rates less than 10% in the setting. And at least according to SOSAP, this was the best answer. All right, let's. Yeah, I guess one of the big questions is also, I think Dr. Fournier brought this up, is, the agents. So if you think about it, a lot of the agents that are currently being used in HIPEC are agents that have presumably failed systemically. And so, one of the big questions that I think we're trying to answer now is, well, why use these same agents, and what new agents can we use? And so a lot of the current efforts are really to try and have preclinical and eventually clinical data support the use of immunotherapies as a use of with direct peritoneal administration. So that's something that we're looking into doing. Any other questions? All right, sorry to keep you guys over.
Sorry, I thought you were on call. Oh no, it's my fault. It was on the.
I tried really hard to block this concept.
Sorry, no worries, man.
Incidental radiologic finding of gallbladder high drops with no symptoms. But the patient was really anxious about
How'd your LAR go?
Oh, okay.
Did you have one today? No, today was APR.
Oh, I was like, is she having